If you're ready to unlock more better days, to take control of your health, to push past your limits and unleash your full potential, then you're in the right place. I'm your host, Dr. Jeremy Bettle. For over 2 decades, I've worked with elite athletes and high performers, helping them optimize their bodies, strengthen their minds, and recover from setbacks. Now I'm bringing that expertise to you through the Vitality Collective podcast. In each episode, we'll dive deep into the science, strategies, and real-world solutions you can apply right away. Whether it's enhancing your physical performance, avoiding or recovering from injury, sharpening your mental edge, or simply feeling your best every single day. With insights from top experts and thought leaders, this podcast is designed to help you take action, feel better, and live the life that you deserve. Welcome to the Vitality Collective podcast, where every day is vital. Today, I'm joined by Ben Ashworth, a renowned physiotherapist and founder of Athletic Shoulder, specializing in shoulder performance and rehabilitation. In this episode, we dive into why the shoulder is so often misunderstood, explore how age impacts function differently, and uncover the real reason so many people end up sidelined by pain. If you've ever wondered how to reclaim overhead mobility, avoid surgery, or build bulletproof shoulders that last a lifetime, this conversation's for you. Let's get started. Welcome back, everybody. I'm so excited for our audience today to be able to learn from Ben Ashworth. Ben, welcome.
Thanks very much for having me. It's been in the pipeline for a while, so it's lovely to be in the hot seat.
Yeah, really excited to have you on. Ben, we're going to talk today about one of the most common issues that I see, and that's shoulder pathologies. We see so much as people age and so much conflicting advice. And so I'm really excited to dig into that with you today. And we'd just like to start right away with, why is the shoulder so complex?
I mean, it is complex for people who don't have a way of simplifying it.
Yeah.
Right. And I think it's because of this kind of myth that it's complex that people don't want to dig in and try and understand it. Actually, it's the same as any other joint in the body. It's just a bit more mobile, and subject to being exposed to vulnerable positions. And I suppose apart from walking, which uses your lower limbs and hips, you sort of don't realize there's how much you use the shoulder until you lose function in the shoulder. So it's a really important area of the body, and the complexity comes from the fact that it is very mobile, and at the same time you've got to maintain a level of stability to be able to function pain-free and to be able to do what you need to do. So therein lies the complexity.
Right. And so can you talk us through the anatomy a little bit? What makes up the shoulder? Because you just sort of think of it as this joint that you see right here, the arm attaches to the body and that's your shoulder.
Yeah. So, I mean, a good way of thinking about the shoulder is that it's not just in isolation, as you suggested, this ball and socket, that actually it's the shoulder girdle, which connects to the neck, connects to the back, and ultimately through those connections connects to the ground through the lower body. So if you look at the shoulder itself, it's a ball and socket joint, but the socket is made from the shoulder blade, which then gives you a lot of different degrees of freedom to position the arm in space. So that's the structure, the articular, the bones. And then around it, then you've got local muscles, the cuff around the shoulder, the core of the shoulder, the rotator cuff, which does its best to try and keep the ball on the socket and the socket on the ball. And then around the shoulder blade, you've got another group of muscles that try and help you stabilize the shoulder blade. Outside of that, then, though, you've got a lot of powerful muscles that attach there too and connect the arm to the spine, connect the arm to the pelvis.
Well, that's amazing. It really gives us a good and really simple view of that whole shoulder girdle. And talk us through that mobility and stability piece then. How how is that created? We'll start, I guess, with the mobility. How is that created and allows that joint to be so multi-directional?
Yeah, so the shoulder, the rotation in the shoulder itself, if you just look at the ball and socket, there's a lot of play, there's a lot of rotation. If you think about, you know, baseball players and
Mm-hmm.
gymnasts and the types of stuff you'll see in break dancers, it's
Yeah.
a huge amount of range of motion. And that's because of the ball and socket. But then even on top of that, you've then got the shoulder blade, which can move to create more range, putting the
Right.
arm right up behind you and then also
Mm-hmm.
right behind your head. So that is a combination of all those joints, the summation of all
Right.
those ranges of motion across those joints. And then you've got the spine, so the trunk and how that rotates to put the arm in a position as well.
Right. Right.
That's why you've got so many degrees of freedom in
Yeah.
terms of mobility.
Right. And then I guess that naturally leads to a certain level of instability, and where we then need to be able to keep our shoulders strong in those extreme ranges.
Yeah, that's absolutely right. So anywhere where you've got an increased range of motion, there is a higher demand to stabilize it.
Mm-hmm.
And I think, yeah, the challenge is how we're designed is that the muscles around the shoulder are, are designed probably more for mobility
Yeah.
to allow us to get those the mobility. We need a bit of play within the joint, so not just the rotation, but also how it moves around and has a bit of looseness within the joint as well. If it
Right.
was very stable, we just wouldn't have any of the mobility we have. So most people have what we describe as laxity and
Mm-hmm.
a little bit of play within the joint. That is totally normal. But when things go wrong, that laxity gets to a higher level and it causes instability. So it goes
Right.
outside of the normal constraints of the joint. And that's when we start to get some problems.
And I see with the people that I'm working with now, I've gone through an athletic career where we went all the way through with these young athletes, particularly hockey, but then also to a lesser extent basketball in a lot of overhead movements. And you start seeing these pathologies sort of creeping in, really starting with some of the tendinopathies and then progressing if left unaddressed. And certainly now with our longevity clients who are 50s and up, we really start to see some more extreme cases coming in. Can you talk a little bit about your experience and some of the pathologies you see developing?
Yeah, we see the spectrum. We see 14-year-olds, young athlete, academy athletes. And a lot of the shoulders we see are actually in athletes, but we see general population as well.
Mm-hmm.
And I think the interesting thing is almost regardless of age, whether you're young and you think you're going to be more unstable, and those are the injuries we see very early on are the instabilities. When
Right.
things are maturing and you're developing into a mature adult, it's probably more a stability demand, and those are the kind of injuries we see. Whereas as we get older, things become compressed and a little bit worn, and just like the lower body, we see degeneration, a bit of wear and tear. And instead of seeing these kind of younger tissues becoming like the tendinopathies that you described,
Mm-hmm.
we see rotator cuff tears.
Right.
We see arthritic joints like the AC joint, like the acromioclavicular joint at the end of the collarbone. We see
Mm-hmm.
the shoulder joint surface itself gets a little bit worn. And regardless of the age, though, what we need to think about is kind of the programming that we're using and the
Right.
exposure that person has had, regardless of age. So a young shoulder can thrive, so can an old shoulder. It just
Right.
depends on how you set up to manage it, and those things are going to be a little bit different.
Yeah. Again, we talk about management. You and I chatted just before we started about a lot of the advice that
that's being given, which is stop lifting overhead if your shoulder's a little sore, or even not. So almost prophylactically with throwing activities, just stop doing that. It's bad for your shoulder. Michelle went to see a shoulder specialist, I think, when she was 30, and the advice was, "Oh, just stop doing yoga." She's a yoga instructor. Talk us through where some of this is coming from, and how should we be looking at those movements?
Well, I suppose that it's interesting. I mean, I went to play an old boys cricket game, and there was a guy doing some throw downs, so very similar to kind of what you'd see, and just throwing a ball in the backyard at your kids. He was doing some throw downs, and he started overarm, and then after 3 he stopped and he started to throw underarm. And I said, "Oh, have you got a shoulder problem?" He said, "No." I said, "Sorry." He said, "Well, I stopped playing rugby when I was about 39, and I battered my shoulders up, and I just don't throw now because it hurts." And so that is what we see. We see this loss of function. There's no requirement or purpose for them to continue to do that. They can live their life without going overhead and throwing, so then they just adapt. But at the end of the day, the realization is not there for some reason in people. There's a blind spot to it, that actually you could improve yourself to be able to still enjoy some time in the backyard throwing at your kids and throwing overarm, and I think that's just, if it ain't broke, don't fix it, is one of the things. But then the other way of looking at it is use it or lose it. So that's probably the biggest mantra for the shoulders as they get older, is the older shoulder is use it or lose it. And that's what we see people stop using their shoulder, their training age drops down. Even in younger athletes, they might do a lot of lower body training, but actually the upper body training age is very low. So thinking about your basketball players, even tennis players, at a young age, they probably don't spend a lot of time on upper body strengthening and conditioning, compared to what they would spend looking at the lower body. And it's just probably the myth that's been created that actually the shoulder doesn't need to be strong. Which is wrong.
It's bizarre, isn't it? Because when you look at the forces that go through the shoulder, a baseball pitch is the most violent action in sport. And I've never really understood, whatever the injury site of a sport is, people tend to shy away from it. In soccer, football, don't train the hamstrings. In ice hockey, it was don't train the groins. And I see it in overhead athletes in baseball and such. We don't go overhead. And it's interesting that is the reinforcing loop. You don't train it, so you get hurt. So you don't train it, so you get hurt. And what I love about what you're saying, the reason we chose vitality over longevity is, and we're a strength-based longevity program, we want to keep you having access to the things that you love, because that's what's going to keep you active. It's what's going to stop you getting the chronic diseases. It's what's going to keep you as a part of your social connection. So all of a sudden, you said it perfectly, we see people's worlds starting to shrink as they withdraw from their activities. My shoulder hurts, I stopped playing tennis, I stopped playing cricket, and all of a sudden your social community's gone as well. And this comes to a client that I was just talking to you about. She's 78, 79 years old, and we just went to do a basic stretch where she was going to extend her arm overhead, and she had no idea, but it wouldn't go. And she just stopped doing that over time, had just used her other arm, and now her left arm was stuck in at the side of her body. So fascinating to see that, and almost unconsciously, as you've trained yourself to back out of activity.
I think there's a sort of anti-gravity element to this, and from a spinal perspective, we know the sort of gravity can be a heavy weight on your shoulders, right? And it's almost compression. Same thing for the shoulder itself. So if you think about that, if it's a problem with gravity, how do we work the anti-gravity muscles? How do we train? How do we train you to stay more upright? How do we train you to fight the potential deterioration through aging, which is which is an inevitable consequence, but it's not an absolute right or an absolute rule that you are going to deteriorate, and that's about exposure,
right?
And the right amount of exposure to it. So yes, you might have to play with the frequency of exposure or the volume or the intensity as you go older, and maybe the recovery is a little bit a bit less. But you talked about that lady who was, I think you said 70, she's struggling to raise her arm overhead. There are veteran javelin throwers, 80 years old, who are throwing the javelin.
Right.
So there's no excuse.
Yeah, that's right. That's right.
There's no excuse.
So talk me through that progression a little bit then. So, and she was a world champion volleyball player, beach volleyball, dominated the sport into her 50s. Yeah. And she's a force of nature. Just, we're rehabbing her right now from double hip replacement. She's just had a second one done, and she's already out walking for an hour and all the rest of it. But this was a real blind spot for her. So how does one go from being very active and overhead and no problem into now I can barely take my arm away from my side. I'm lacking internal or external rotation. How do we get there?
I've just been in America, so you can see these catchphrases coming out a little bit more. But, the other one I use is, if you're not assessing, you're guessing, right? So if you don't have a reference point, like a daily check-in where you go, can I get into that overhead position? You've got no idea whether that is deteriorating over a week, a month, half a year, no reference point. So that in itself is important, a check-in, somewhere you can look at the key things around low tech, it doesn't need to be high tech, but a low tech check-in of what's your overhead range looking like. And we use a specific test, which is really low tech, using a stick, to look at whether someone can get overhead.
Yeah.
And then we look at what's your strength like, and that can be broken down again into, could be how much weight you're moving in a particular exercise, and suddenly you start to feel like that's dropping off compared to normal. But if you've got a consistent habit, a consistent check-in and a reference, the endurance, which I think the two things that I think the older shoulder needs more than anything is mobility to enable people to access a good position, and then endurance, the conditioning element, and that's the thing that sort of deteriorates. So you can do it once, you can do it twice, but when you're asked to do it 10 or 20 times, you don't have that anymore, and that's what starts to almost shrink things in, as you said. So those two things are the maintenance behind then being able to go and do higher intensity work still.
Yeah.
To allow you to expose yourself to that more frequently without fatigue and soreness and stuff that would actually prevent you then training and consistently training.
Yeah. And what's going on at the tissue level there?
With regard to the mobility?
With regard to sort of, let's talk about like frozen shoulder, for example, or somebody really lacking mobility. What's going on within those complex joints and soft tissues that you described?
Well, I think this anti-gravity, limb dominance, being on their phone, carrying, a lot of things with one side particularly can lead you to almost a bit of an imbalance.
Right.
And then what takes over is usually these kind of larger, more powerful muscle groups that kind of pull on the shoulder girdle and pull it out of a nice upright posture. And so at tissue level, if things are allowed to shorten over time, they will, and they'll happily get into the path of least resistance, which is to sit in a shortened position. So thinking about, if we're talking about applications here, your front of your chest tightening up through your pecs, that's an inevitable consequence of not doing something to open up. It's very difficult to stay in a good upright position when you're sitting all day, or you're on your phone, or you're driving, so it's probably about the 23 and a half hours a day you're not thinking about mobility, that the problem's happening. rather than when you go to the gym and do your mobility. But what we need is regular doses of exposure to mobility to stop you getting into those more kind of constrained positions.
Mm-hmm.
I think that's normal anyway. And then a frozen shoulder is actually a pathology. So
Right.
there's lots of reasons why you might get frozen shoulder. And a true frozen shoulder is a pathological change to the shoulder capsule.
Right.
That in itself.
Can I just stop you there? Can you describe what is the shoulder capsule?
So the shoulder capsule is the passive layer around the joint, which basically keeps in place the fluid within the joint to lubricate the joint surfaces. And it's also reinforced by capsular ligaments. So it creates some of the stability, although not a lot of the stability in the shoulder, but some of the stability around the shoulder. That's what the capsule does. Okay,
so it's sort of the closest layer in of that soft tissue around the joint itself, and then we go out into the rotator cuff and the larger musculature. Okay. Great. Yeah, thanks for that. And so what changes occur at that capsule level then?
Well, you get an adaptation, you get thickening. There's studies that look at how things change there, and it can be almost like a contracture. So you might have seen things like trigger finger and other changes. Those changes can happen within the capsule in a broad sense, in a basic sense. Probably triggered by probably triggered by an incident which is quite innocuous, an overstretch. Can be that you've spent some time immobilized after an operation and you've had your arm in a sling, and again some inflammation, some thickening, and then almost a vicious circle that creates this actual frozen shoulder where the capsule itself actually becomes quite restricted.
Right. Okay. And how easy is that to address? I guess what's the first stop that people should consider when they realize they're in that boat?
I mean, definitely seek medical advice, because if it is a true capsular pattern, the normal course of events is that, it will get stiff and painful. And there are things that we can do to mitigate against that, to prevent that getting worse. Some thoughts that we can shorten the time course of that as well, using pain relief, whether that be acupuncture, soft tissue work, whether that's an injection that your physician might suggest. There are multiple ways of reducing pain, and then ultimately that's then going to allow you to keep moving, because the problem is when it's painful, it's very difficult to move, things stiffen up, and then that creates this vicious cycle of deterioration. And then you're basically playing a waiting game almost. Once you've got an active, angry, frozen shoulder, it's not it's not a nice place for anybody to be. The physio, the patient, because you've got to go through a great deal of pain to maintain some range of motion. So if you do get that, it's a true frozen shoulder, or you after 2 weeks things aren't easing, you need to get in and see someone. If you think you've got some stiffness, maybe you can't reach up behind your back as well, or you can't wash behind your head as well. Those are probably signs that you should get some advice. And it can mimic other things which can be treated really easily, but if it is a frozen shoulder, you need to get at it as soon as possible.
Yeah, how would you differentiate between a stiff shoulder and a true frozen shoulder? Is that literally just diagnosis?
Usually a clinical diagnosis. We can look at, we talk about external rotation, but the arm by your side in an L-shaped position. This is a visual one, but the arm by your side in an L-shaped position and turning out to the side. You can normally tease that if you don't have a frozen shoulder. So you might have some shoulder pain, but actually it's not the capsule that's restricting you. Whereas if you've got a true frozen shoulder, that tends to become stiff. So when we compare to the opposite side, you'll see and feel a difference. It feels more restricted. It feels a bit more blocked on the frozen shoulder side. And that's a sort of, it's starting to progress by that stage into a frozen shoulder stage, rather than that kind of freezing phase where it's getting a bit painful and it's starting to get a bit more functionally limited.
Yeah, and will that stretch feel painful as you start to move someone into that range of motion?
Yeah, the normal stretch on a joint might give you a 1 or a 2 discomfort at the very end,
Yeah,
whereas a sort of painful stiff shoulder, when it starts to do that, it's a bit more angry. It's probably like a 5 out of 10 plus.
right, right.
And so, yeah, if there's a big difference between your unaffected and your affected side, then that's probably a sign that something isn't right. And you need to seek some advice.
Yeah. And would it respond, despite the pain, would it respond to stretching like a regular stiff musculature would?
It will respond. The problem is it's the balance between the dose of how much you can do without the soreness.
Yeah.
And that comes down to each individual's capability to almost cope with that.
Mm-hmm.
And as I say, there are useful things that can help settle pain down. Obviously guidance from your physician on this,
Yeah.
but medications,
Yeah.
injections, basically anti-inflammatory, even though it's not always
Yeah.
inflammation that's causing it, but anti-inflammatories and pain relief to help you basically do what you need to do, which is to do the mobility, the movement, the stretching. So there is hope with those, but actually, having worked with a few of them myself, you have to also educate. And that's one of the biggest things around this is, look, this has happened. Explain it. Explaining it helps, because otherwise it's quite frightening. There's a lot on the internet. You Google it, you see frozen shoulder, and hear all the horror stories.
Yeah.
But fundamentally, this is going to take some time. And these are the best things we can do for it. Just knowing that, although it's not great news, is enough to then stop people worrying about the short-term effects.
Yeah.
Is this irreversible? No. It naturally resolves in most people. So actually that dampens down fear avoidance behavior, which is another thing that can create concern and worry and stop people moving.
Yeah. Yeah, it's such a valuable point there, because this is something I see throughout the body and in all different sports, all different joints. It hurts, and so we favor something else. We stop doing an activity. It hurts more, and we start avoiding, and that problem really develops. I also love that we're not completely against some sort of medication, something to alleviate the pain. We often discuss that with our clients, of whatever gives us access to do the work we need to do. I think there's a couple of confusions here. They don't want to work through any discomfort through fear of injury. But there's also this thought that take the medication, it stops hurting. Great, problem's been solved. And so I think the combination of layering these interventions is a really important point.
Yeah. I mean, both of us have worked in elite sport environments, and we'd have some pretty clear models and frameworks around that based on, wanting no pain in a muscle injury context versus a joint related pain where you can allow a little bit of bandwidth for some discomfort.
Yeah.
A tendon that's grumbling, again, it's not going to be pain free, but how do we dampen it down to a tolerable level to enable someone to do what they need to do? And those are the things. But I think ultimately, like, any injury does not equal inactivity. Even if you're put in a sling by someone to protect your shoulder, you should still be doing stuff to try and, you should be asking the question, what can I do? Not what can't I do?
Yeah.
That's the key.
And that's, if there's one takeaway from this, I just think that is such an important point, that the inactivity is never the answer in any way. You hurt your back, you hurt your shoulder, you hurt your neck. Inactivity is always going to make things worse.
Definitely. And I challenge surgeons on this. Again, we work hand in hand with any surgeon. We abide by protocols, whether it's an elite athlete or someone whose demands, they've got a bit more time maybe and less pressure to push. But I'll always ask the question, like, why can't we? Why can't we move? Right. How much, are we truly restricted to neutral, or have we got a bit of bandwidth to move a little bit further? Do you mean they can't get above their shoulder height, or can we from what you've seen in surgery, can we take them a little bit further? Yeah, there's no reason. There's no problem with the repair we've done. There's nothing to stop you accessing a bit more range. And that then buys us a window to, basically the longer you allow things to sit inactive, the worse state the person is when they then start rehab.
Yes.
And then outcomes are worse. That's so important. Understanding the current state of the person in front of you, is about understanding how much deterioration they've had based on this injury. They're not at their normal level. How much do you normally shoulder press? Well, I normally shoulder press 10 kilograms for 10 reps. Okay. But now you've had surgery, you're 4 weeks post-operation, maybe a yellow TheraBand is enough of a stimulus for strength because you've dropped so significantly.
Yes.
But that's so critical to understand that, because otherwise people start to chase it too early without building the necessary building blocks to get them back to the start line. I think that's critical. For me, the sooner you start after a period of protective phase, that could be 72 hours or 2 weeks, the sooner you can start, the better. The sooner you can introduce something to stop deterioration, whether that's muscle atrophy, whether that's stiffening, as soon as you can start that, you're in a much better place.
Yeah, and I think that speaks really well to the sort of load management of a joint, and both in injury prevention, we alluded to keep that function and keep the endurance, keep training it so that we maintain a high level of resilience. But once we've taken that step back, if we've had a surgery or if we've had some sort of pathology develop, progressing back in a way that does take us above our level, but doesn't take us too far above our level.
Yeah.
I think that's such a valuable thing for people, again, to take away, is you can't just start back where you were.
No.
You can't set that expectation. You have to be realistic with where you are and make those gradual progressions.
Absolutely. And the thing is, though, with highly motivated people, like, types of people that you and I work with and understand and know, they will try.
Yeah.
They won't wait for you to let them. So, I actually managed to chin up the other day.
Right.
And so you sort of, did you?
Okay. How'd that go?
Yeah. How did that go for you?
Yeah,
well, I just tried a couple. Well, they will probably be able to try a couple, in some instances. But it's, as we said at the start, it's that sustainability, consistency. Those one-off performances, those one reps, most people can do it. But I suspect when we look under the surface, the legs are paddling, right? It's not going to look beautiful. They might achieve it, but it's not in a really nice, beautiful, shared force, lovely mobility, manner. So therefore, it's probably going to lead to cheating, compensation, and then that in itself can interfere with getting back to a nice, healthy, strong shoulder.
Yeah, we would always have this conversation with coaches. Like, the most dangerous time in a rehab was when we first let the guy put his skates back on.
Yeah. Coach
sees him in skates, he's ready.
Yeah.
And it's the same thing. And then the athlete's like, well, I feel great. Well, of course you do, because we've put the guard rails around you. You feel great doing what we've allowed you to do.
Yeah.
And to be able to take those guardrails away, we need to pass certain checkpoints and know that we're safe to do that. And then, as you said with the coach, could this athlete go out there and play tonight's game? Probably. Will they get hurt in a week of games? Most likely.
Yeah.
Right? So how we reintroduce activity, I think, is so critical.
It's the confidence that you have around the ability to return and sustain that return. That's the thing. So we talk about return to performance, but it's sustained performance. It's, there's a great guy, Phil Glasgow, who talks about thriving, not just surviving.
Mm-hmm.
That's what our aim is, not just that one-off performance. And just touching back on a point you made earlier around sort of using stuff to, like medication or things to to dampen down the pain, to unlock the door, to allow you to access the ability to train. As you said, and rightly so, I think that education is so important. Like, they will feel much better when you do that.
Yeah.
But the plan doesn't change.
Exactly. Yes.
It doesn't accelerate their return to their sport. It allows them to do the stuff that's going to prepare them for their sport.
Yeah.
And that's really important. That's really important. It's eyes wide open.
Yeah.
If we do this for you and you feel amazing, don't.
Yeah. Right.
Yeah. And that's that risk management, which is ultimately what we all do, isn't it? It's risk management.
Yeah. Based
on the demand, based on the level they're at. That's what we're doing.
And I think that's a really important application of the nuance of experience and expertise. Is we're not using painkillers as may have been used in the past to get people back to playing.
No.
Right? You're injured. Here's a painkiller. Just don't feel it anymore. Go and play. It's a tool in the tool belt to allow us access to the program. And I think letting people know either how much pain they can push through or the kinds of pain they can push through, and also the level of activity they're cleared for, would be critical. Yeah. I'm rehabbing a guy right now who had a back injury, and when he first had the injury, 2 months out, he had booked a cortisone injection. And we were having this conversation, should I keep this appointment? And I was just sort of saying, well, we're at the point where you've still got some nagging pain, so it wouldn't hurt us to go ahead and have it. But to your point, understand what that means. And he ended up deciding not to go and have it because he knew he would do exactly what you said. It'd feel great. Our training would be over, right? And he'd go back to doing all sorts of stuff he shouldn't and be right back where he was.
Yeah. Exactly that.
So moving on from the frozen shoulder, the other things we see, certainly in this longevity group, are wear and tear on the rotator cuff. Even down to, as we get into our 80s, people have got several tears within the cuff. They're not going to repair it. What is going on there in that progression towards a rotator cuff tear? And I guess, where can people start, or what should people be doing early to prevent it? But if we find ourselves in a position where we've now got it, what are the strategies to maintain all of this strength, stability, range of motion once we have these pathologies going on?
Yeah. I think a lot of what we do, my business is almost agnostic to the type of pathology we have. We treat each person. We functionally assess the different buckets, if you like, the mobility, the endurance, the strength, and the power. And we look at that regardless of what we see on an MRI scan. So that's really important, because you'll have the same result on an MRI scan, but you'll have a totally different level of function in the athlete in front of you.
Right.
I saw a 78-year-old owner of a golf and country club who loves his golf. And I was sent his MRI scan. And when I had the appointment with him, I said, do you want to know what your MRI scan says? He said, do I? I said, no. Right. Let's go through some testing. So we tested him. We found some weaknesses, largely in his strength of his external rotators, so his rotator cuff and the back of the rotator cuff, which often deteriorates. Yeah, because people don't do the necessary exercises to maintain that. So then we just gave him a simple program, a mobility program, to open up and access and create space. That's critical. It's like, firstly, create space, then add some load. And so what we did was exactly that. We taught him how to keep a nice upright shoulder position when he's exercising, start on quite low weights, doing some of the rotator cuff exercises, and very quickly, because he's super diligent and a highly competitive individual, he very quickly, in 2 weeks, massively changed his shoulder strength scores, which we'd measured using some technology. Sure. 78-year-old, looking at the data behind some strength tests, empowered by that to change it. What should I be at? Well, actually, we've got some data on some 70-year-old tennis players, some veteran, veteran tennis players, some other people, some other golfers. This is what normal looks like.
Right.
Oh, wow, I'm way off. How do I get from
Right.
A to B? Right. This is how you do it. And he did it every day and made something like, 45% change in the space of 2 weeks.
Incredible.
Which is unheard
At
of.
78 years old.
And he's shot, he's shooting sub 80. So, I mean, he could play.
Yeah.
He can play anyway. But if you look at the MRI scan, you would naturally shut him down, assume he couldn't be playing golf. I actually assessed him. And then next time I saw him at the golf club. And I had a bit of time at the end and I went and watched him hit some golf balls. And I mean, it was phenomenal the way he's hitting a golf ball at his age. But often we're in a clinic, aren't we? We assess the person, we listen to them. I play a bit of golf. I play a bit of paddle. I play a bit of tennis. Actually, in reality, this guy, I've never played as good golf as this guy. And he's 78 years old.
Yeah.
So again, age is not the limiting factor.
Yeah.
When we come back to the stuff that he had on the MRI scan, the deterioration, and going back to the original part of your question, is because things get compressed.
Mm-hmm. And that's the gravity thing, I guess, like where those spaces.
I mean, most people, and this is the myth that needs to be busted more than anything, is people have been told to put their shoulder blades in their back pockets.
Yeah.
And what that does, in simple terms, is it brings the roof down.
Yeah.
And the contents of the room then are squeezed. So we need to lift the roof up. And most of the time that means getting in a nice, upright, big chest posture.
Yeah.
That might make 4 millimeters of difference in how much pressure is being placed on your small rotator cuff that's trying to do the work. But if it's trying to work and it's being squished,
right,
gradually over time, we're going to get a bit of wear and tear on the top or underneath.
Yeah.
And then what happens is then you get a bit of weakness, and some of those smaller muscles with smaller attachments then aren't offloaded, and they get high forces through those little areas, and they're just not designed to take it. So that's why they start to tear, to partial tear, to full thickness tear. And that's basically what's happening.
Mm-hmm. Yeah. And 4 millimeters in a space that is typically like 8 to 10 millimeters is significant. Might sound like a small deal.
It's the difference between being symptomatic and asymptomatic.
Yeah.
So, when we're making those small changes in posture, when we're making small changes in the tension within a muscle, it can shift someone from in the space of 30 minutes from being in pain to out of pain when they lift their arms overhead. Whilst that's not the end of it, that gives us that allows us to see that conservative management and non-surgical management can actually help these people. We just need to put in the right re-education process, the right exercises to address some of those key deficits.
Yeah. And I think within that, the access to a whole range of expertise is really important here. Recognizing that your surgeon doesn't hold all of the answers. He holds a very important piece of knowledge and experience, but then your physical therapist holds another extension on top of that of knowledge. And then a really good strength and conditioning coach will help you with that sort of return to performance piece, that thriving piece where we go beyond just your basic yellow TheraBand and into now we're training for the demands of golf.
Yeah.
Right. These are sort of high velocity pieces, and each one has a very nuanced piece of experience and knowledge there.
Yeah, they do. And that's exactly right. We're used to working in an environment where all of those things from the continuum are available to us, from the diagnostics through to that return to performance and technical coaching, but scaled down into our own day-to-day. Me as a non-elite athlete who wants to go and do something and maintain a level of function, I should always have a diagnosis.
Yeah.
Because I think what a lot of people do is they go, well, it's dysfunctional, there's some movement problems, but let's understand what the structural limitations are. And that's where the surgeon can come in, or the doctor, and the diagnostics are really useful. It's like, is there anything here that we can't treat and manage conservatively? Right. Because if that's the case, we're pushing a square peg in a round hole.
Right.
And we may come to a conclusion that, yes, they do need surgery, but then we're just giving them information. So, yes, we think you need surgery, or we think you need an injection. Well, thanks for that information, but actually that doesn't work for me right now. I want to try. I want to try conservative management. I want to try strength conditioning. I want to try this, because I'd rather be at 80%, and not have to have an operation, and I'd be happy with that.
Mm-hmm.
Well, then, as long as they understand the risks and the rewards, and we've clearly outlined them to that using the members of the team, then they can make an informed decision on what they want to do. And I think that's not copping out. That's just really supporting the individual, rather than thinking about it from a pathology, or from a, it can be very medicalized. And what we're trying to do is consider feelings and and confidences.
I see it over and over again, and again, not just at the shoulder, but all over. We rehabbed a hamstring injury that a guy had for, I want to say, a year and a half, and kept going to his doctor. I'm going to get PRP, I'm going to get stem cells, I'm going to get, it was always a medical intervention. And 6 months of strength training, and it went away. But then he went back and got an MRI, no symptoms, nothing going on, and there's still fluid in that hamstring. Well, how's it feeling? And so just having people know that they have options outside of those medical interventions, not that we don't need them when we need them, but there are always options. When people take a conservative approach to their shoulder health, what would be that cutoff, would you say, in terms of, okay, we tried this, maybe I do need surgery?
Well, it comes back to, I won't accept being 80%. My level of function isn't good enough for me. I feel like we progress, but I can't do what I want to do. So an inhibited level of performance, pain that starts to affect sleep, sharper pain that's frequent, that lasts, those suggest high levels of irritability and impact on the person's daily life and what they want to do. That's when you have to start to consider surgical options. And there are rarely things that need to be done immediately from a surgical perspective. Like, there's some ideal things, like if you tear your pec major from the bone, that you need to be seen very quickly. Some people say within the first 2 weeks, but otherwise, there aren't necessarily a lot of issues. Even rotator cuff repairs left a little bit later, although again, there's arguments about outcomes. You can do something later on. Mm-hmm. And the risk of doing a rotator cuff repair is that, especially in an aging population, it can create post-operative stiffness and then lead to a secondary frozen shoulder. So the education, again, around the risks is really important. It's not a guarantee that you're going to come back straight away if we repair this. You might not be any better. And in fact, it could be worse for a while. Those are really important pieces of information to help people make those decisions.
And these are really big surgeries. I don't think people realize that, this could be a 9-month, 12-month rehab. And so there's that to take into account. Are you willing to put in 12 months to get back to where you were? It'll be progressively better as we go along, but this is not a 6-week, quick turnaround here.
Yeah, that's right. And time frame, I mean, for me, I never use a time frame, because I use markers and phases and stages. And we say, well, look, the likelihood is for someone of your age, with the amount of training you can fit into a week, we're not talking 10 weeks here. We're probably talking, 6 months for you, based on your likelihood to be able to do it. But how fast can you get better? Well, it depends how many times you can train, usually.
Right.
And it depends on the team you've got around you. So if money's no object, and you can get regular soft tissue work, you can get or you can access a strength and conditioning coach or physio, and or you're covered to do that. It's so worthwhile getting that guidance in those early phases when you can make a real difference. And I think that's probably goes against what we've been told, which is that post-surgery, right, we'll just do nothing for 4 weeks.
Yes.
And then start.
Yes.
The damage is already done.
Right.
Yeah.
Right. Yeah. Now we're almost rehabbing from that period of inactivity on top of having to rehab the surgery. Yeah.
Yeah. Muscle atrophy. What can we do in the meantime? We could use some muscle stim. We could use some isometrics. We can use something. And I think, even though isometrics are a buzz worldwide in multiple sports and domains, for an older shoulder, an isometric is gold.
Yeah.
Absolute gold, because you're not angering joints by dynamically moving them through range. Some of these degenerative joints, like the AC joint, like the shoulder joint itself, you are getting load in a safe, comfortable position, and you give your brain the realization that you can still produce a lot of force because nothing's inhibiting you doing it. And then that leads to you then opening the door to them going back into a bit more upper body training.
Oh, I love that. And if people have got to the point where they have several complete tears in the rotator cuff, I love the fact that we're not reading the MRI, we're going on function. What are the best methods for them to get this back? Is it the isometrics or range of motion? What do you recommend people do there?
Based on the usual suspects that we see people tightening up through their chest, through their a little bit through their neck, because that compensates a lot. You tend to hitch up because you can't get your shoulder up as easily. So a general mobility is so important, and that's worth, in an older shoulder, spending 15 minutes on every morning, and possibly even going back to later in the day. So that's really important. And then the advice then with the isometrics would be, start to introduce a load that you consider to be a 70% effort in a safe part of the range. Now, if that's pushing against a wall, if that's pushing against your own hand, or if that's using a weight to add or a band to add a bit of resistance, again, setting up a nice open chest position and then starting to load progressively up into more overhead positions will allow that adaptation to occur without you cheating. Then you've got the idea of, the high frequency dosing, so the micro dosing. So if you did something every 4 hours, it's better than doing a 45-minute block. 6 minutes every 4 hours, it's better than doing 45 minutes, in a one go, because fatigue actually reduces stability and it can start to overload and create compensation. When we expose things frequently, especially in the older shoulder, we can accumulate load over a period of weeks without the same cost. Less soreness, better recovery. So that's really important. And for everybody, there'll be a sweet spot to how much they can do in a week. Little and often.
And what does that microdose look like? Give me an example of what I might do.
So let's say you've worked your way up, you can get yourself into even early on, and even in athletes at the end stage of return to play, we might lie someone on their side, put a towel under their arm, and they're just holding a weight in an L-shaped position, right? So a side lying external rotation. If you Google it, you'll see that. What that looks like is probably a longer duration hold, something like 10 seconds, at a weight that you feel is a 7 out of 10 effort. So if you put 5 kilograms in your hand and you weigh 80 kilograms and you hold it there, you say, well, that's a 7 out of 10 effort for 10 seconds. Next week, you're putting a 6 in your hand and it's a 7 out of 10 effort. And actually, if you're 80 kilograms, the target we set is you can get to 8 kilograms if you're an 80 kilogram person holding it for 10 seconds. Now, that is for an elite group.
Right.
So we might have to take a little bit off. But why would we? Because as we've said, like strength declines are probably not relevant to aging.
Right. Exactly.
What can you do at 7 out of 10 effort? If it becomes a 10 kilogram in your hand and you're 70 years old, well played.
Exactly right. Exactly. Yeah. I think putting arbitrary limits on people because of age has been the most infuriating thing about coming out of sport. Me progressing an 80-year-old woman as she can, and people say, oh, I don't think she needs to do that. She's 80. Well, how much force is going to be applied through her lower body if she trips and has to catch herself?
Yeah.
Does that change because she's 80? Or is she going to fall and break her hip? Right? If she puts her arm down, is that force coming through the shoulder going to be any less? So I couldn't agree more with that fact of we progress people as they can in a safe and pain-free manner. But if they can lift more, they lift more.
Yeah. And I think, even at me challenging myself on this is like, why would you see strength decline? And I actually looked on, there's a website, which is strengthlevel.com.
Mm-hmm.
And it has age-related kind of normative values across the demographic of the population based on people just entering what they're doing. So it's a huge body of evidence, which isn't published. But you look at that and you look at the best people at the age of 65, female and male, what should they be dumbbell pressing? And it's very impressive.
Yeah, right. It is. These numbers are surprising, aren't they?
Yeah, I mean, and that's the thing is the training age of the individual and the consistent build up to that level. That repeated nature of that resistance training is so important, especially in, and I'm no female health expert or women of a certain age expert, but essentially, again, like, oh, well, we're going to deteriorate 10%, perimenopausal, or I'm a guy, I'm 50 years old, I'm going to deteriorate by 1% lean muscle mass for the rest of my life from here.
Right.
Well, not if you haven't been doing any strength training in your upper body for the past 5 years. You stopped playing rugby age 30, you haven't done anything till you're 50. You could build like that guy. You could build 45% increase in your force output in 2 weeks because you've started from such a low state.
We saw a 75% increase in quad strength in a 75-year-old male.
Amazing.
We've had 50-60% increase in our 80-year-old females. Everybody at every age can improve. Yep. And I don't see a ceiling on it right now. We keep challenging, we keep progressing and developing the program. And it's amazing the improvements that we can see at all ages.
Yeah.
And that there are just so many arbitrary limitations put on us and an expectation that it's inevitable. And I think that's just a decline given no stimulus.
Exactly.
Right? If you sit around, you're going to get weaker. And that's going to be a terrible outcome for you. You're going to get into frailty, and your last 2-3 decades are going to be a real struggle for you.
Yeah, there are a lot of things that we can do from an educational perspective to in the youth athletes, as we discussed, to build better foundations, but also in the older athlete to halt deterioration. And actually, not just that. It's like I read a bit, and there's a book, Anti-Fragile.
Yes.
Right.
Yeah. Nassim Taleb.
Yeah, exactly. Nassim Nicholas Taleb. So basically, the opposite of fragile is not robust.
Mm-hmm.
It's anti-fragile, which means not only can you stop yourself being fragile, you can actually improve yourself.
Yes.
And the example that he gives, or one of the examples he gives in there, is strength training.
Yeah.
And the fact that you not only are you stopping deterioration, but you are improving strength outputs, improving force outputs. That's so important. You think alongside strength training and how that might affect hormonal profiles and other things, general health and well-being, as well, I hope.
Yeah, please.
Going into veterans competitions and starting to win lifting and making some money off it. Well, that would be
be nice, wouldn't it?
bonus, yeah.
Well, seriously, if we think about think about the impact on the brain of weight training.
Yeah.
Not by, yes, both from a hormonal profile, but also, BDNF production and all these other factors that actually help maintain and grow new brain cells at every stage of life. So being able to stay active within your career, to stay sharp, to stay at the top of your game, it's a critical part for these cognitive athletes of maintaining your brain function, your cognitive outputs.
I just thought about that. There's a really cool guy that works with handball. He works with tennis actually. And talking about like anti-gravity stuff, anti-fragile, anti-gravity.
Yeah.
He describes a melting candle.
Yeah.
Right. So imagine someone holding a tennis racket overhead, and all you see is just everything just like buckling. From the wrist, the elbow, the hand, the back, the knees, the feet. And so all our training should then be about, well, can we almost get that into a place where we're working to stop that melting candle, right? We're going to keep that flame alive essentially, right? So from the ground up, and this is what we went back to the start, it's not just a shoulder in isolation, it's from the ground. Lower body strength training can improve shoulder health and function. So even when you've had an operation or you're sore for a bit, or you're actually doing some leg strength work, will have a huge impact, not only on the things you've just described, but also actually on the ability to create and transfer force, so that when that soreness is gone, actually you haven't lost the ability to connect the arm to the rest of your body, which is so crucial in anything, any performance that we have.
Yeah, thanks for highlighting that. That again is a thing that I've seen coming out of sport, is that the body is trained in segments. Like we do a lower body day, a core day, and an upper body day. And those two never intermingle. And when I first see people and assess them, it's amazing that they've never done anything to connect essentially the ground to the hand, right? That transferring that force through the lower body, through the core, through the shoulder, and those slings that are so important in transitioning force. And no wonder your shoulder hurts if it's been in isolation, just trying to do all this stuff on its own. Where I think in sport, it's a little more intuitive to train the full movement and to train for function. It really isn't making its way into your regular personal training gyms. And it's amazing to see, really.
Yeah. And you can vary your base of support. You can go into a split kneeling position, a step stance position, just doing a normal cable row or a band row versus seated. And just that, and even if you were to change it up and do one set, which is a little bit more involving the whole chain, versus one that's a bit more stable in sitting, again, you can mix it up a little bit, because ultimately we're probably not going for that 1 rep maximum, right? Unless we're a veteran powerlifter or something like that. But the risk reward comes in there. It's like, can we consistently put in place some nice, steady, progressive loading with good recovery in between bouts? How you set that up across a week and periodize that, even in the older athlete, is, well, in fact, probably more so in the older athlete. You can take advantage of that recovery window and get in different muscle groups with different push, pull, maybe a day where you're just doing some cuff work. Over a course of a week, actually, it might look at 5 different mini sessions rather than 2 big sessions. And then that's going to probably lead to better improvement.
Yeah, absolutely. And Ben, as we wrap up here, what are your 3 priorities that someone could take away from today and start implementing right away?
Yeah. So, I mean, if we're allowed to do it, we'll have a mobility routine in every day, 15 minutes, that hits the key usual suspects, which is the pecs. So opening up the chest, opening up the lats and the side of the trunk. And again, like, we've got YouTube channels and videos on all this, but we can share that. those are critical. And then also that just easy cross-body stretch as well. So taking the shoulder through all of its potential ranges to make sure you're having a check-in. And then if there's any areas that are feeling a bit gritty, get those moving and spend some time restoring normal range of motion before you train. Otherwise, you're not accessing a nice start position.
Right.
Then I think the other part we talked about at the start, people skip this to go to strength training, but really it's capacity, it's endurance. So simple things like band openers with your thumbs pointing back, or dare I say it, the old reverse flies.
Oh.
Yeah, the forgotten exercise. It's a beauty.
Right. Yeah.
Those things that are working your anti-gravity muscles, so pulling your shoulders back with a little bit of load, so some technique under resistance work where you're moving nicely but putting a bit of resistance for sort of 10 to 12 reps, even 12 to 15. Something you can do at that sort of level in a warm-up after you've done your mobility is great. And you can do that every day because there's no physical cost to do that. If you can put those two things in, then I think the third thing is to target the areas that are really important for shoulder health. And most of the time, that's around the back of your rotator cuff. So being able to do something for what we'd loosely call your external rotator muscle group. So not getting too specific, but can we put in place an isometric hold? Dumbbell, arm against the wall, elbow slightly in front of the body, and just putting a weight in your hands and just holding it there for 10 seconds. And I believe that most people aren't at their full capability on their exercise.
Yeah.
And actually, because of that and the lack of strength they have in those muscles, that's why they get all these rotator cuff tears and these impingements and other things that tend to haunt that kind of transition of 40 to 50-year-old.
Yeah. Well, Ben, thank you so much for your time today. And I just want to say those resources that you mentioned, I've learned a ton from them. I've implemented them in my training with my clients and athletes. So thanks for putting those out. Where can people find your work?
Yeah, so my company is Athletic Shoulder. And so we're on Instagram at Athletic Shoulder. You can go to the website, www.athleticshoulder.com. And there's a huge amount of free resources. We've got a YouTube channel as well, where we've got just a load of exercises. And I suppose then in future and what's coming out is we will actually release an older shoulder program and resource towards the back end of the year. Just because we are, as you are, seeing a lot of people who've retired from sport who still want to maintain a good, healthy level. And, we found decent ways of supporting them. So there'll be more and more coming out in those areas, which will be free content that you can find there.
Amazing. Well, thanks so much for that. And we'll make sure all of those are in the show notes. Ben, thanks so much again for your time this morning.
It's an absolute pleasure.
Here are 3 key takeaways from today's episode with Ben Ashworth. Number 1, mobility matters. Daily check-ins and stretches can preserve range of motion and stop deterioration before it starts. Number 2, endurance equals longevity. Build your shoulder stabilizers with high-frequency, low-load exercises for long-term function. Number 3, function first, scans second. Rehab should be guided by what you can do, not just what an MRI says. If today's discussion resonated with you and you're looking for ways to integrate early detection, personalized health strategies, and strength-based longevity into your own life, visit www.vitality-collective.com to learn more. Thanks for listening, and we'll see you next time.